Superficial thrombophlebitis is a thrombosis of the superficial veins, and these superficial veins, as we stated earlier, are the veins which are situated superficial to the deep fascia and are widely distributed all over the body. Its exact incidence and prevalence have never been adequately assessed because of the frequency of the encountering of these superficial thrombophlebitis. But its incidence increases as the age advances in both men and women. Overall, its incidence in the lower extremity is ranging from 3 to 11%. For a practical point of view, it can be viewed as superficial thrombophlebitis occurring in varicose veins and those which are otherwise in the normal veins. When it comes to its cause, usually there is no direct cause for the development of these superficial thrombophlebitis, but always there is risk factors. These risk factors can follow the Virchow's triad. Virchow was a German pathologist in the 19th century, and his theory about the development of the thrombosis is still valid to now. This is constitutes three things: endothelial injury, stasis, and hypercoagulable state. Can be viewed as a triangle, and this triangle is formed of three sides. One side of this triangle, the endothelial injury, and the other, the venous stasis, and the third one is the hypercoagulability. They are interplaying with each other. There is no single factor for the development of this superficial thrombophlebitis. Trauma and indwelling catheter constitutes injury to the endothelium. This injury of the endothelium will bring about the superficial thrombophlebitis. Indwelling catheters are frequently used in the clinical practice. Therefore, the superficial thrombophlebitis has its highest incidence in the upper limb. About 38% of cases of superficial thrombophlebitis occurs in the upper limb, and the cephalic vein is being involved in about 58% of the cases. Injury to the endothelium upon the advancement of this catheter into the vein can incite this endothelial injury and lead to superficial thrombophlebitis. Moreover, the infused substances through this indwelling catheter could be injurious to the endothelium, bring about what's called chemical injury. This chemical injury due to the composition of the substance being infused through this catheter. The common example is the IV fluids containing potassium and chemotherapeutic used for the treatment of malignancy. Comes next is the stasis. Varicose veins are known for areas of the veins with turbulence of the blood flow and stagnation of the blood within. This can also bring about the development of the superficial thrombophlebitis. Lastly, the hypercoagulable state, in which it is a state that there is an imbalance between the normal coagulation and normal anticoagulations naturally occurring in the human body. The common example for this is the factor V Leiden, prothrombin G mutation, protein C, protein S, and antithrombin 3 deficiency, malignancy, thrombocytosis, and polycythemia rubra vera. We have other risk factors. This includes the obesity, pregnancy, prolonged recumbency, surgery, particularly major surgery, hormonal and radiation therapy. There is special entities of the superficial thrombophlebitis worth mentioning. This is migratory thrombophlebitis, which is called the Trousseau syndrome, in which there is thrombophlebitis of the superficial vein, one behind, one after the other, as if the superficial thrombophlebitis is fleeting from one vein to other, as if chasing the superficial veins. It has been found that it could presentation of underlying hidden malignancy, and they can precede the diagnosis of this hidden malignancy, particularly carcinoma of the pancreas, by several years. Also, it can occur in the Behçet, Buerger's disease, and the polyarthritis nodosa, or could be a hallmark for hypercoagulability state. Mondor's disease is another special form of superficial thrombophlebitis affecting the superficial veins of the chest, and also this disease can describe superficial thrombophlebitis in the dorsal vein of the penis. This is the picture. It shows superficial thrombophlebitis of the veins of the chest wall in case of the Mondor's disease. There is a fear for the involvement of the deep veins in case of the superficial thrombophlebitis. In fact, the importance of the superficial thrombophlebitis stems from these complications. The superficial thrombophlebitis can extend to the deep vein, and therefore pulmonary embolism could be a grave sequel to that. Could also accompany the deep veins, and you can read a duplex report saying that there is deep veins with extension, for example, to the great saphenous vein. The clinical presentation, it follows the picture of inflammation anywhere. That's pain, redness, hotness, tenderness, but they are confined to the course of the affected vein and often associated with palpable tender cord. The ultrasound should be performed in such context, not for the diagnosis of the superficial thrombophlebitis only, which is evident on the clinical examination, but to exclude the involvement of the deep veins and to prevent an overlocked deep vein thrombosis and its sequelae, which is potentially fatal pulmonary embolism. Concomitant deep vein thrombosis of the lower limb occurs in 5% to 40% of the cases of the superficial thrombophlebitis, particularly if this superficial thrombophlebitis involves the great saphenous vein within 1 centimeter below the saphenofemoral junction. Treatment of the superficial thrombophlebitis is easy, but it varies according to the severity and the location. The available options are low molecular weight heparin, anti-inflammatory, suitable compression, rosary, antibiotics, and rarely surgical excision of the involved veins. This surgical excision is reserved for the cases with septic thrombophlebitis and rarely used in such context. Superficial thrombophlebitis located more than 1 centimeter of the saphenofemoral junction can give the patient anti-inflammatory, systemic and local, prophylactic dose of low molecular weight heparin for 1 week. Some of authors recommend the use of antibiotic in addition, and compression rosary will suffice. When it comes to superficial thrombophlebitis within 1 centimeter of the saphenofemoral junction, which, as we mentioned earlier, carries a great risk of extension to the deep system. We have 2 options for this. The first option is the surgical ligation, and the proponents for this surgical ligation is to prevent the extension to the deep system. But it had been found that conservative management can prevent extension to the deep system as well, and both conservative management and surgical ligation are equally effective. Conservative treatment, what does it constitute? It constitutes anticoagulants for at least 6 weeks, and this can be extended to up to 3 months. First by low molecular weight heparin, followed by suitable oral anticoagulants. Thank you, and please stay put.